Good morning, sir.
Good morning, Mansari.
Welcome, sir.
So, no problem. Going on fine.
Hello.
Hello. Tell me,
Sir, yes, sir. Sir, I opened the room for attendance. You can start, sir.
Yeah, please open the room. Yeah.
Sir, I opened the room.
Okay, thank you. I'll wait for 2 more minutes and then we'll go. Just 2 minutes.
Okay, sir. Okay.
Good evening, sir.
Good evening, Amarji. Get a surprise to your list, though.
അടുത്ത ആഴ്ച തന്നെ നോമ്പാ സാർ. ആ ടൈമിൽ ചിലപ്പോ
ശരി
ഞാൻ കഴിയത്ര ഞാൻ നോക്കും സാർ. ട്രൈ. ഓക്കെ സാർ. ഓക്കെ സാർ.
ഗുഡ് ഈവനിങ് സർ. റെജി.
റെജി ഹാപ്പി. ഒരുപാട് നാളായി കണ്ടിട്ട്.
സോ സോറി സർ. ഞാൻ ആക്ച്വലി ഇപ്പൊ ഡ്രൈവിംഗിന്റെ ഇടയ്ക്കാണ്. ഞാൻ പെട്ടെന്ന് സാറിന്റെ കാര്യം ഓർത്തപ്പോഴത്തേനും ഞാൻ പെട്ടെന്ന് നോക്കിയപ്പോഴാണ് ആലോചിച്ചപ്പോഴാണ് സാർ ഇന്ന് ഇത് പ്രോഗ്രാം ഉണ്ടല്ലോ എന്ന് ഓർത്തത്. അപ്പൊ ഓൺ ചെയ്തതാണ്.
ഓക്കെ, ശരി റെജി, നമുക്ക് സ്റ്റാർട്ട് ചെയ്യാം. 2 minutes ആയി. ഓക്കെ, ശരി. Okay, good evening to all of you. As usual, I will start with the short case first. Is my screen visible to you all?
Yes, sir.
Yeah, right.
Yes.
Yeah, thank you. So this is a story of a 60-year-old man who was a known case of diabetes mellitus and depression on treatment for the last 1 year. Came with history of acute onset of imbalance while walking and generalized tremulousness of the body 4 days back. He was seen by a local physician and was put on treatment, which did not produce any significant improvement. That is why he was referred over here. This is a video of the patient. I look carefully for the operculars and ocular. I did not see. The ocular movements are all normal. Fixations like that also abnormal movement. Ocular movements are all normal. Examination. But he has found such tremulousness of the both hands, and they are outstretched. Something not a typical tremor, something more like a mini polymicron. They are irregular.
டச் பண்ண வேண்டாம், அப்படியே கிட்ட இங்கே டச் பண்ணுங்க. இனி மூக்கில் தொடுங்க.
There is no coordination per se except for that.
மூக்கில் தொடுங்க. இந்த கைனால முறுக்கி பிடிங்க, நல்லா முறுக்கி பிடிங்க. இது முறுக்கி பிடிங்க. விட்டுருங்க. இப்படி போக்குங்க. கால் போக்குங்க.
Whatever examination rating is normal.
கீழே வைங்க. இது போக்குங்க. போக்குங்க.
The reflexes are all normal.
கல் கொடுக்காதீங்க.
Intakes were normal.
கொடுக்காதீங்க.
Thanks so much.
കാല്
Matter
വലിക്കാതെ
seems to be upgoing occasionally. I'm not sure there is
ചുമ്മാ പോടുங்க വലിക്കാതെங்க.
there is no other evidence of any clinical signs. Upgoing. We're trying to the angle check. There is a jerking movement in the left toe. If you cannot hold his left toe, it just goes on jerking.
പുള്ളി കൺട്രോൾ ചെയ്യാൻ പറ്റുന്നില്ല.
The might not sit again, might
ചുമ്മാ ചുമ്മാ പോടുங்க, ചുമ്മാ
not
പോടുங்க,
keep it at rest.
ചുമ്மா പോടുங்க. കാല് നേരെ
Angle
வைங்க, നേരെ
is
வைங்க.
normal.
കാല് നൂർത്തി ഇരിപ്പ്.
Vibration was normal. Sensations are all normal.
இது தெரியுதா? தெரியுதுல்ல? இதுவும் தெரியுதுல்ல?
I think the film pattern once again. Yes. Kept going out all the time. Upper reflex is however intact. Look at the gait of the patient. He has a tremolousness when getting down. What's the standing close together also is the
நான் பக்கத்துல நிக்கேனா తీసుకుంటే ఈ మనిషి పాడు అంటే ఫీలింగ్ అంటే இங்க பாருங்க, இங்க பாருங்க, இங்க போடு, இங்க
it was otherwise normal except for the mild imbalance due to the feminist. So on examination, no spontaneous eye movement. Ocular movements were normal. Postocularis normal. Motor system normal. TTR all normal. Down reflex normal. Plantar Cori abgoi or Cori indefinite. Sensations normal. Generalized tremulousness of the body. Bilateral postal tremor or mini polymacronis of both hands when outstretched. Stands generalized tremulousness of the body while standing. Tandem walking was defective. So what do you think the patient is likely to be having? Acute onset for the last 4 days.
Metabolic, sir. More likely metabolic, probably drug induced.
Yeah, most likely metabolic. So metabolic, what the thing you have to keep in mind. In fact, subsequently, I will tell you the investigation later on. Otherwise, there's no altered sensorium per se. It's slightly dull in between. Otherwise, normal.
So even in his eyes, I think there is some sort of some oscillation, some macrocyclic oscillation, something like that. It's just.
No, in fact, I looked for it very carefully. That is the diagnosis which I had in mind. Frankly speaking, I did not see that. Sometimes obstructionis macronus did not have obstructionis. Only macronus may be dominant. As you said, it's correct. Yeah. Any other possibility anyone like to keep?
Post-viral.
Post-viral, yes. Yeah. Because usually this obstructionis macronus can be either, if you know, can be a paraneoplastic, can be many MD number of causes, metabolic, high diabetes, many things can toxicity, toluene. But usual things are post-viral and second is paraneoplastic. There is another possibility, which we did not have any fever preceding that, but that's a possibility can be ruled out. Yes. So this is initially what I thought in a person for macronus.
Renal,
Pardon?
renal, any renal failure.
Yeah, that's metabolic. It tops on the important DD is the metabolic encephalopathy. That characteristic for the multifocal macronus, perfectly right. So MRI brain, he came with in fact MRI brain. Yeah, anyone else want to make a comment, please? This MRI brain. T2-weight MRI brain did not show any cerebellar involvement. But in FLIR, there is subtle hyperdensity in the cerebellar cortex. Not very convincing, but that's only abnormality found in the MRI, which may not be correct. Cori hyperdensity. So this is initially what I thought. Now, patient was given first dose of IVMP. So any other possibility you want to keep? All metabolic workup normal, LFT, RFT, serum ammonia, electrolytes were normal.
Sir, is there any medial temporal hyperintensity on both sides?
That sometimes you can see in FLIR, you can see, if it is bilaterally seen like that, it is often normal. there is hypertension can be normally seen in middle tunnel lobe.
Any hypoxia or any COPD like carbon dioxide
No.
narcosis?
No, nothing.
Thyroid, sir.
Pardon? Pardon?
Thyroid.
Thyroid is also normal.
CSF done, sir? CSF?
Pardon?
CSF was done, sir?
No, CSO was not done. I did something else. We should ask to bring his old psychiatric prescription. He bought it next day. This is what the prescription had. Sosed 50 milligram BD, venlafaxine 100 milligram HS, and Mirtas 15 milligram bedtime.
Serotonin syndrome.
Yeah, that's a serotonin syndrome. So I stopped all the medication and put him on cyproheptadine and improved. So this very often we don't ask the patient to bring the prescription. See, he has been taking this for very long, and off and down the psychiatrist will change the medication. In fact, he has to change the medication which was done about 2 weeks back. That is why this whole thing is unmasked, the serotonin syndrome, because taking so many drugs which produces increased level of serotonin in the serum. So I think I'll skip that. Only to just one slide on that. In mild cases, the predominating features are mild hypertension, tachycardia, mydriasis, diaphoresis, shivering, tremor, myoclonus, hyperreflexia. Patients with mild symptoms are usually febrile. With moderate symptoms, they usually have the above symptoms plus hyperthermia, hyperactive bowel sounds, horizontal ocular clonus, mild agitation, hypervigilance, and pressured speech. In severe cases, patients have all the above symptoms plus hyperthermia greater than 41.1 degrees centigrade. Okay, some case, rare case, severe cases can result in complications like seizures, rhabdomyolysis, myoglobinuria, metabolic acidosis, etc. Okay, shall we go to the next case?
How much cyproheptadine was done for? How much
Pardon?
cyproheptadine? How much?
How many?
Cyproheptadine. How much was given? Cyproheptadine?
I beat it, 4 milligram BD dosage I gave. Along with clonazepam, I gave clonazepam and cyproheptadine. Clonazepam for myoclonus. But it took 1 week for him to recover. Even though I stopped the medication immediately, everything was stopped, but still it took 1 week.
So CPK, neuroleptic malignant syndrome.
Yeah, that's another condition you have to keep in mind, neuroleptic malignant syndrome. That's often can be confused with the serotonin syndrome. They can also present with hyperthermia. But here the hyperthermia occurs in severe cases. The 2-3 important differentiating point is one is the mydriasis and the diarrhea, which are seen only in serotonin syndrome.
Severe rigidity in NMS.
Yeah, the other things will be marked rigidity, hyperthermia, stiffness. That's the thing. Elevated CPK and all in hyperthermia. Not malignant hyperthermia, neuroleptic malignant syndrome. There is another DD which comes. Shall I go to the next case?
Yes, sir.
Yeah. So next to this case is little more good, but anyway, we'll start with this case first. This is a story of a 56-year-old man. This case belongs to Dr. Roy from Travancore Medicity. He came with numbness of the left side of the chest and abdomen for the last 4 months. He noticed clumsiness of the left hand in the form of inability to approximate his fingers to one another for the last. He was showing like this. I cannot approximate like that for the last 2 months. No other complaint. This only complaint he came. No neck pain, no root pain, no other kind of symptoms, no difficulty in walking. So summarizing, numbness of the left side of the chest and abdomen, not in the hand. Clumsiness of the left hand in the form of inability to approximate the fingers. So these are the findings in this patient. The cranial examination looked for Horner syndrome, which was not there.
മുറുകട്ടെ മാക്സിമം മതി മതി.
All guidelines were
കണ്ണ്
normal.
തുറന്നോളൂ. കല്യാണിച്ച് കണ്ണ് തുറന്നോളൂ. വാ തുറന്ന് വാ തുറക്ക്. ആന്ന് പറഞ്ഞ് മതി. നാക്ക് നീട്ടിക്ക്. ഇങ്ങനെ എന്നെ നോക്കാം. മതി. എല്ലാം കൊടുക്കണ്ട.
Neck muscles were normal.
ശരി കേട്ടോ. ബലം കൊടുക്കണ്ട.
Tone is normal in the left upper, both upper limbs.
എല്ലാം കളിച്ച്.
Deltoid normal power.
ഇനി അകത്തോട്ട് പിടിച്ചോ.
Biceps normal. Bilaterally. Triceps normal. See, look at the wrist extension was normal.
ഈ വിരല് പൊക്കിക്ക്.
Finger extension is normal bilaterally. Mild weakness in control. Not very convincing.
ഈ വിരല് മടക്കിക്ക്.
Finger press normal on the right side, but weak on the left side. All the long finger flexors were weak.
പൊക്കിക്ക്.
I check the wrist extension and flexion again. They are normal. Wrist flexion was normal. Wrist extension was normal, but finger flexors were weak.
അതേപോലെ ഇത് പൊക്കിക്ക്. കറക്റ്റ്. ഇനി അതേപോലെ ഈ വിരല് ഇങ്ങനെ മടക്കി പിടിച്ചിരിക്കുന്നത്. ഇത് മടക്കി പിടിച്ച്
Easily I can overcome all finger.
അറ്റം മടക്കിക്ക്.
Before principles preferences in each fingers.
ഇനി അറ്റം വിട്ട്
Normal on the right side.
അറ്റം മടങ്ങാതെ ഇങ്ങനെ ഇരിക്കണമേ. അകത്തോട്ട് ഇങ്ങനെ വരട്ടെ. അകത്തോട്ട് ഇങ്ങനെ പിടിക്കണമേ. പിടിച്ച് നിർത്തിക്കോ.
Principles is very good.
ഇതുപോലെ ഇത് പിടിച്ച് നിർത്താം. ഇല്ല കാണിക്കാം. ഇങ്ങനെ ഇരിക്കണം. ദൂർക്കാൻ സമ്മതിക്കരുത്.
That is weak. Principles is previous weak on the left side.
അതേമാതിരി ഇതിങ്ങനെ കൈ മത്സരുത്.
Is also weak.
ഇങ്ങനെ പെട്ടതില്ല.
You cannot even hold it in the abducted position.
ഇനി വിട്ടോ. ഞാൻ പിടിച്ചു തരാം. വിട്ടെ. ഇങ്ങനെ പിടിച്ചിട്ട് ഇതിങ്ങനെ ഇരിക്കുക. അത് തന്നെ.
That is normal on the right side.
മനസ്സിലായി. അതേപോലെ ഇതിങ്ങനെ ഇരിക്കണം.
That is weak. The left side.
അത് മടങ്ങാതെ ഇങ്ങനെ വരുന്നത് കണ്ട.
Principles previous also weak on the left side.
ശരി. ഇനി ഓരോ വിരലും മടക്കണം. അറ്റം മടക്കിക്ക്.
Openness was all openness of all the fingers were weak.
ഇതും പിടിച്ചോ. മടക്കി പിടിച്ചോ. പിടിച്ചോ. ഇത് പിടിച്ചോ.
There was no pointing index sign. It's only mildly weakness.
വിട്ടോ. ഇത് ആദ്യം പിടിച്ചോ.
The introsia were also weak on the left side compared to the right side. Protected digit minimi and the introsia.
പിടിച്ച് നിർത്താൻ നോക്ക്.
Performance is positive on the left side.
ശരി വിട്ടോ. അല്ലാതെ അടയ്ക്കണേ. നോക്ക് പിടിച്ച് നോക്കി. ശരി. മറ്റേ കേണ്ടി.
There is no finger nose incoordination. Lower limb examination, tone power normal. Power was all normal.
ഇത് മടക്കിക്ക്. അത് ചവിട്ടി അത് വെരി ഗുഡ്. അതേമാതിരി ചവിട്ടി മാറ്റണ്ടേ. മതി. ഈ പാദം മുകളിലോട്ട് ഇരിക്കണം. ഇവിടെയൊക്കെ സമ്മതിക്കും. ഇത് നോക്കിക്ക്. ചവിട്ടിക്ക്. ചവിട്ടി. അതിനകത്ത് പിടിച്ച് ചേർത്ത് വെച്ചോ. ചേർത്ത് വെച്ച്.
Reflexes, right upper limb reflexes were normal. Left biceps was brisk. Supinus also markedly brisk on the left side. Brisk. Right supinated normally elicited. Triceps on the other side was decreased or normally elicited or decreased. Compared to right triceps, left triceps is less. Finger pressure was absent bilateral. Abdominal reflex was absent bilaterally. Knee jerks were brisk. Maybe slightly more brisk on the left side. Ankle jerk was normally elicited. Left leg is covered. Plantar was upgoing on the left, normal on the right side. That is what's upgoing on the left side. Descent system was normal.
ഒന്നും അറിയാമല്ലോ.
The pain has decreased the lateral side of the chest. Upper limbs are all normal.
ഇത് രണ്ടും ഒരേപോലെ.
It's an equal. Both the fingers are all equal.
ഇത് രണ്ടും ഇതും ഒരേപോലെയാണോ? ഇത് രണ്ടും വ്യത്യാസമില്ലല്ലോ. ഞാനിങ്ങനെ കുത്തി വരുമ്പോഴേ എവിടെയെങ്കിലും ആ കുത്തുന്ന അറിയുന്നതിന് വ്യത്യാസം ഉണ്ടെങ്കിൽ എൻ്റെ അടുത്ത് പറയണം. എന്നെ ഒരേപോലെ ഇനിയും കുത്തി വരുമ്പോഴേയാണോ പറയണം. ആണ്.
Is it all normal?
ഈ കുത്തുന്നതും ഇത് ഒരേപോലെയാണ്. ഇനി ഈ കുത്തുന്ന
But on the side of the chest, there is decrease on the side of the chest.
ഇതും വ്യത്യാസമുണ്ട്. ഇതും വ്യത്യാസമുണ്ട്. ഇതോ കുത്തുന്നതും ഇതും തമ്മിലാണ് ചെറിയ വ്യത്യാസം. ഈ കുത്തുന്നതും ഇതും തമ്മിലാണ്. അറിഞ്ഞോടം പറയണം.
Left side of the chest and abdomen.
നോർമലായി. ഇനി നോർമലാകുമ്പോൾ പറയണം.
Become normal near the middle. It's become normal there.
ഇനി ടച്ചും കൈ പൊക്കിക്കാം. ഈ കുത്തുന്നതും ഇതും തമ്മിൽ വ്യത്യാസമുണ്ട്.
So the axilla is less on the left side.
ഇതും തമ്മിൽ
The middle part of the arm is normal.
ഇതും തമ്മിൽ സെയിം. ഇപ്പം എന്തെങ്കിലും തോന്നുന്നു?
Memory is normal in all the fingers.
ഇപ്പോഴാ ഉണ്ട്. ആ തണുപ്പൂടെ ഉണ്ട്. അത്രയില്ല. ഇപ്പോഴും നല്ല തണുപ്പുണ്ട്.
Temperature also decrease the same area.
അത്രയും തണുപ്പില്ല. നല്ല തണുപ്പുണ്ട്. വ്യത്യാസമുണ്ട്.
But less, you feeling less coldness on the left side.
ചെറിയ വ്യത്യാസം. തണുപ്പും ഇതും തമ്മിലോ ചെറിയ വ്യത്യാസം. ഇപ്പോഴേ താഴോട്ട്, ഇപ്പോഴേ മേപ്പോട്ട്, ഇപ്പോഴേ മേപ്പോട്ട്. അതേമാതിരി ചെറുവിരലി
Joints are normal.
താഴോട്ട്, ഇപ്പോഴേ മേപ്പോട്ട്, ഇപ്പോഴേ മേപ്പോട്ട്. അതേമാതിരി കൈ പറയണേ, ശ്രദ്ധിച്ചിരിക്കണേ. ഇപ്പോഴോ താഴോട്ട്, ഇപ്പോഴേ താഴോട്ട്, ഇപ്പോഴോ മേപ്പോട്ട്, ഇപ്പോഴോ മേപ്പോട്ട്, ഇപ്പോഴേ താഴോട്ട്, ഇപ്പോഴേ ഇപ്പോഴോ താഴോട്ട്, ഇപ്പോഴോ അത്ര ഷുഗറല്ല.
Mild pain with the little finger.
ഇപ്പോഴേ മേപ്പോട്ട്,
It's clear on that side.
ഇപ്പോഴേ മേപ്പോട്ട്, ഇപ്പോഴേ
It's clear on that side. Slowly normal.
ഇപ്പോഴേ ഇപ്പോഴേ ശരി.
On gait, gait is normal. Focus negative. Standard walking was normal. Okay, so cranial examination, all normal. No Horner syndrome, no nystagmus. Motor system, mild wasting of the thenar hypothenar muscles on the left side. Tone normal in both upper and lower limbs. Power, left upper limb. Shoulder and elbow muscles were normal on the left side. Right side all normal. Wrist flexion and extension normal. Weakness of all finger flexors. Our finger extensions were normal. Weakness of flexor pollicis longus. All thenar, hypothenar muscles are interossei and adductor pollicis on the left side. On the right upper limb, mild weakness of the interossei, questionable. Other muscles are all normal. Once again, I will mention that the wrist weakness of finger flexors, but finger extensions are normal. Wrist flexion was normal. Lower limb normal for both upper limb, both lower limb. Detail, right upper limb, all normal, but right finger flexion reflex was not elicited. Biceps on the left side, biceps open brisk compared to the right side. Left triceps is sluggish compared to the right. Left finger flexion, just like right side, is not elicited. Detail of the lower limb, knee jerks brisk bilaterally, ankle jerk normal bilaterally, maybe slightly more, better elicited on the left side. Abdominal reflex absent bilaterally, plantar right flexor left upgoing. So sensation, touch normal in all areas. Pain impaired of the left lateral chest and abdomen. Temperature also diminished in the same area. The area which is I marked is the area which is affected. Maybe extending to the axilla also, which I forgot to mark. Vibration normal. JPS is impaired over the left little finger. All other fingers it is normal. Rhombus positive, gait normal. And a walking normal. So if you want to see the findings once again, I can go back and show the findings. This is sensory, these are the reflexes and findings.
And
Where do you want to localize the lesion?
cervical cord, sir.
Okay, cervical cord, I think we see which area is affected. Above C5 at C7 or in the extramedullary compression, intramedullary, or some other.
It's a left D7 with a anterior involvement involved in the D8, DTT1. Predominantly is on the left side, and pyramidal tract on the same side, as well as the crossing fibers on the same side.
Okay.
Possible?
Okay, so you want to consider intramedullary lesion.
Yes, sir.
Okay. Any other possibility?
C7, sir.
Yeah, could be C7, C8 radiculopathy with myelopathy is another possibility which you have to keep in mind. Okay, right? Which would you prefer? C7, C8 radiculopathy with the cord lesion on that left side, or an intramedullary lesion? Intramedullary. Okay. How to explain the brisk biceps and supinate on the left side with intramedullary?
That couldn't be explained. So this may be a constitutional, or he may be having a pre-existing myelopathy, or a high cortical lesion on the left.
Yeah, that cannot be explained by intramedullary. Okay, all what is said is all correct. Now let me ask you one question now. See, what are the points against ellipsis and radiculopathy? That's the first thing to do before coming into intramedullary. What is against?
Finger extensors are
right. Correct. That's the point. 2 points are there. One, he has got weakness of the finger flex with normal wrist flexion. Okay. Second, finger flexors are weak, finger extensors are normal. Okay. So if it is there, it should, even if it is C7, C8 radiculopathy, it should have been affected. Both of them should have been affected. But that two muscle groups are spared. That means it cannot be localized either to the nerve or to the root. Okay.
So the problem is that suppose if we bring a high up lesion, so the sensory loss cannot be explained by a cortical lesion.
No, it cannot be explained cortically. Moreover, I'll tell you on the other point against C7, C8 radiculopathy compression is what? Because his pain loss is on the same side, not on the opposite side. That's another point against an extramedullary compression. The lesion has to be inside, cutting off the crossing fibers, as Umar has already mentioned. So these are the points against an extramedullary compression because they are supplied by the same route. For example, if you say take the C7 route, it supplies the extensor digitorum. Okay, that is not weak here, and it also supplies the carpial radialis. That is not weak here. Because C8 radiculopathy can be explained with the most of the things, but the other thing, C7 contribution cannot be explained. And the extensor carpi ulnar is also supplied by the C8, which is also spared here in this picture. So it is not fitting with the distribution of a root. That's the first thing to understand. Second thing, so the lesion is likely to be in the anterior console. What's the other thing is that you can't explain the brisk repress of the biceps supinator with the C7 radiculopathy. You have to think of a lesion above that. How to explain the pain loss over the left lateral chest? Again, you can't explain by extramedullary. So the lesion is likely to be in the left C7, C8 anterior consoles on the left side, which are extended medially to cut the crossing fibers on the same side, like this. These are pain fibers going up like that. It's initially affected the anterior horn cells. With the lesion little more lower down, has crossed the opposite side and affected the crossing fibers on the same side. That is, the pain loss is occurring on the same side in the intramedullary region. If it was in the central region, it should have cut off both the fibers. And my question now is, why should I have lost joint presence sense on the left index finger? How to explain that thing? That means this lesion at that level has extended into the dorsal root and tree zone. Lesion must have been here, extending here. It's a long lesion, but it's got a ramification. Some areas it is enlarged to one area, some areas it is enlarged to the other area. So how to explain the bliss by superior? You cannot explain by this intramedullary lesion per se. Lesion is extending up, you expect that reflex has to be absent. But or you have to only way to explain is there is another lesion above C5 on the left side. That's only way to explain it by logic thinking. Or the same lesion has got becoming more prominent on one side than the other side. Okay, so what investigation you want?
Absent abdominal reflexes.
Pardon? Absent abdominal bilateral, because you have not only left pyramidal, bilateral pyramidal tract is affected. So that can be explained by any lesion, either extramedullary or intramedullary. You can explain that thing by compression.
So when triceps jerk is diminished.
Yeah, that's again that's showing that that can occur with his own radiculopathy or a segment involved.
When triceps jerk is diminished, biceps and supinator may be brisk because of the antagonistic muscles will.
You have got a point there. That's a weak that occurs only when the muscle is weak. Here the muscle is not weak. So the triceps muscle, they're not weak at all. Only that difference is mildly decreased. That alone cannot cause a brisk reflexes per se.
Clinically, 2 levels that considered, or a single lesion, or both internal and external.
Yeah, it's difficult to say whether it's 2 lesions, 1 lesion. Only thing is the lesion has to extend up into the cervical cord with some ramifications. Some areas it may be coming to the pyramidal tract is affected. In other areas, the gray column is more affected. That's only way to explain. Otherwise, difficult to explain by a single lesion. So, what do you want? MRI. This is the MRI. It shows a hyperintense lesion extending from C2 up to C1 downward up to the corners. Up to the lower thoracic region, say about D10 or so. And some areas it is more widened, some areas it's also the axial cut later. This is a T2 axial. This is at C2 level. This is T2. Okay? This again C2, C3 level. But here the central part become hypointense. See, if it is a fluid, it should become hyperintense. It has become hypo. It's again markedly hypo. This is T2. Again hypo. There it becomes a little less hypo. Again, a little less hypo now. Bringing down. Coming down to the thoracic cord. Now it has becoming hyperintense. T1 sagittal cut. This is a T1 sagittal cut. You can see some areas the canal cavity is wider, some other areas canal cavity is small. This is a T1 axial, hypo throughout. T1 contrast. Always when you find a syringomyelia without unknown site malformation, it is a must that you should do contrast study because you may be having an underlying malignancy, somebody not meant to get a tumor like ependymoma, which can have a predominant cystic component mimicking a syringomyelia. So always look for any nodular or focal area of enhancement in the cavity, near the cavity to rule ependymoma. So this is There's no contrast enhancement anywhere.
Is there any issue of trauma?
No stiff trauma. This is contrast. There's no contrast enhancement. Even axial contrast. No, this how to explain this T2 hypointensity in the T2, T2 hypointensity in the center of that cavity. I've shown the corresponding cut on both sides.
If there is a solid lesion,
Pardon?
if there is a something like a soil with a lot.
It's, this is a TN, this is, and the T1 is whole throughout its hypo. Here, just above that, I'll show the picture once again. T2, I'll show the T2. See, this is the T2, the hyperintensity. I look at the axial cut. See, this is the axial cut. So, not a sagittal cut, showing the hyperintensity all throughout. But some areas here in the center, it is hypo. Why is it so? Then it becomes hyper again.
Degenerating tumor, is it a possibility?
No, initially also I was not knowing what it is. It's a CSF flow void. And the CSF is flowing inside the cavity, you can have flow void. At some areas it is not flowing, then you get a hyperdensity. Some areas the CSF is moving, then you get a CSF flow void. That is hypo in T2. This area is flow void is there, just like a thoracic subdural space, subdural space. It has, at other areas, it is this area where there is no flow void. You see some just stagnant there, just like a cavity.
If there is blood inside, is it possible?
Bleeding, blood also is unlikely. It will not produce a forward appearance like this. And moreover, blood should produce T1 hyper. T1 is not hyper. So that's the thing. This is a flow void. It's again showing the three things: T1, T2, and T1 contrast. So, how to explain the brisk left biceps supinator jerk after seeing the film?
Compression of the corticospinal tract.
Pardon?
Compression of the corticospinal tract upwards.
But in that case, no. If it is inside the lesion is inside this gray column, it should have cut off the reflex fibers also. The reason is like this. Sometimes, see, the syringomyelic cavity may not be uniformly dilated throughout. In some areas, it may be more dilated. Some areas, it may be less dilated. Imagine a cavity is occurring in the pyramidal tract here. At certain level, it may be expanding to the involved anterior console. So, for example, C4 level, the pyramidal tract is, the lesion is here, the compression in the pyramidal tract. But there is not much compression in the anterior console, so the reflex carrying fibers. That is why the C4, C5, C6 level, there is no reflex loss. But at the level of C7, C8, the cavity is enlarged to encroach onto the gray column. Cutting of the anterior console, crossing fibers, as well as the anterior console. That's only way to explain by after seeing the MRI. Okay. So, any questions in this case?
Then it should be normal, no, sir. Why exaggerated, sir?
Because the pyramidal tract is affected. The pyramidal tract is affected here above C4. There's a pyramidal lesion at that level. But at that level, that least the cavity has not extended onto the anterior console, so the reflex carrying fibers. That is why the C5 is lesion is above C5.
Okay, sir.
That is why I written C4 here. In fact, the lesion is extending from C2 downwards in the MRI.
Is there any Chiari there, sir?
No,
Chiari
no,
one-
no Chiari malformation. I look for that. There's no Chiari malformation. That is why I say there's no Chiari here.
What will be the cause for this?
This is syringomyelia itself had been remaining for long. Sometime it decided to enlarge and then produce symptoms.
There is a
In
little
fact, in fact,
tonsil is little herniated, no, sir?
tonsil is say more than the descent should be more than 5 millimeters in to call it as descent. This is not a prominent descent at all. This is the tip of the spine. This is the only this much is there. Here again, you see not much of a descent.
Sir, can this be a tumor? What is the?
Yeah, it could be tumor. Only thing is there is no enhancement anywhere. Usually, such a long tumor to produce syringomyelia. Some areas with some solid tumors may be there, no, producing enhancement. It's not there in this patient.
But sir, the tonsil seems to be slightly pushed down as a peg in this case.
Tonsil, this is not, it's a normal descent. It can be seen up to 5 millimeter, can be normal. In children up to 7, in adult up to 5 millimeters can be normal. Usually put such a syringomyelia.
Particular, yeah. Yes, sir.
Okay, shall we go to the next one?
So was he subjected to surgery, sir?
No. Because he gave the option to him, but he started improving by himself. Even though he started, now he's telling that, sir, after coming here, we did not do anything. He started improving by himself. Sometimes this is not hemodynamic or CSF dynamic changes can worsen that syringomyelia a little bit, transiently. So, for example, after strenuous exercise or a violent cough and all, the fluid pressure can increase and produce transient worsening of the deficit, which has been there earlier. That is, it become manifest. He said his weakness is improved spontaneously.
Surgery, what surgery can we advise?
Yeah, can do what in the syringomyelia, what they can do is decompressive surgery. They do.
Shunt.
That is the Brown magnum decompression. Okay, shall I go to the next one? Okay, that's not a very interesting case, but this is going to be an interesting case. Management problem, what to do with this patient. This is a story of a 72-year-old female. This case belongs to Dr. Murli from Lakeshore. Her complaint started in 2018 as difficulty in walking in the form of difficulty in initiating the gait as well as slowness in walking. After about 2 months, she needed support of a person to walk about. No complaints pertaining to the upper limbs or the bladder. No history of any cognitive impairment. So difficulty in walking in the form of slowness and requiring support of one person to walk about. She was seen by a physician. MRI was taken, suspecting normal pressure hydrocephalus. MRI picture taken at that time is given below, which showed features of NPH. This is the MRI at that time, that's 2018. There is a periventricular seepage. Normal pressure hydrocephalus is there. This repeat MRI was done in April 2019, which also showed same but increase in the size with periventricular seepage. So CSF tap was done in April 2019. Patient subject CSF tap, with which her walking difficulty totally improved, almost totally improved. And this is, in fact, the patient's bystanders gave himself the videos to me. But unfortunately, all the videos were after the treatment. That's why we do not know what was the before the tap. This is 2019 after the CSF tap. This is the way she was walking. A very supported person is walking freely without any problem. So, however, after about 3 months, she worsened again. So, the patient was subjected to VP shunt on July 2019, with which she again became all right for next three months. But unfortunately, she developed shunt infection in October 2019, which did not abate with antibiotic treatment, and the shunt had to be removed to control of infection. She recovered from the infection and was healthy till the December 2019. After the shunt removal, her gait worsened again. So in April 2021, a repeat CSF was done, with which patient his gait again improved. This is in April 2010 after video after the CSF tap. These are all the videos sent by the patients later. Then after about 2 months, her gait problem again worsened, and a repeat VP shunt was done on the opposite side in August 2022. With the second VP shunt, patient improved again and was well for the next 6 months. This is after the second VP shunt. This is again October 2022. She was walking without much of a problem. After 5 months, she worsened again after the second, even though the second BP shunt on the opposite side and patient improved. And a shunt block was suspected. However, the neurosurgeon was of opinion that shunt was functioning very well. So in fact, this is a CT scan done at that time when the patient showed worsening. But the ventricle size has come down remarkably well. So in the January 2023, just to find out whether any CSF tap will work in that patient, the shunt block, even though it's not there, may not be training properly. So a CSF tap was done to find out whether this tap could improve her gait. And with the CSF tap, her gait improved again, even though the patient was said to be walking. But that improvement was only transient, and patient continues to complain of walking difficulty, mainly for the initiation of the gait. That is how. That's how the patient is referred over here, and she developed borderline diabetes 5 months back. And when presently patient was referred for the complaint of persistent walking difficulty, despite the fact that VP shunt was told to be working very well. She also complained that she was feeling that her feet were feeling wet most of the time whenever her feet touches the ground, not present at other times. This also she was complaining now. So this is the last video on March, the Western is sent. Relatively well, but short step gait. This is the video sent. So now she was examined now on March, this is not 6263. This is the
Okay. പിടിച്ച് നിർത്തണേ, കീഴോട്ടാക്കാൻ സമ്മതിക്കരുത് കേട്ടോ. ഇതും പൊക്കി പിടിച്ചേ, പൊക്കി പിടിച്ചേ, ചവിട്ടിക്ക് ആദ്യത്തെ തന്നെ പിടിച്ചോ, ഇതും പിടിച്ചോ, ഇനി തള്ളവരിൽ പൊക്കിക്കേ, ഇതും പൊക്കി വിടരില്ലേ, പൊക്കി പിടിച്ചോണ്ടിരിക്കേ, വിട. ഇനി കീഴോട്ട് മടക്ക്, മടക്കിപ്പിടി, മടക്കിപ്പിടി, ഇതും മടക്കി പിടിക്കാം മതിയേ.
Disc on the right side, less on the left side. Right angle just well acceptable. Left angle was absent. It's also diabetic. Plantar was flexor.
അറിയാവോ?
Sensations were not
അറിയാമല്ലോ.
normal.
അല്ലേ അമ്മ? കിരികിരാന്ന്. ഇതും അറിയാം.
Vibration was normal. And this is how the patient was. There's a starting gate initiation problem. And turning around, she has got pivotal turning. Again, some see the problem in turning around. I'll show the another video with this patient.
നടന്നു. തിരിച്ചു നടന്നു. തിരിഞ്ഞു നടന്നു. ഫാസ്റ്റായിട്ട് നടക്കണേ. തിരിച്ചു വാ.
See the difficulty in turning around.
തിരിച്ചു നടന്നു.
So an examination, adrenal function is normal, illness normal, tone power normal, sensory system normal, TTR, upper limb normal, left knee jerk is decreased compared to the right, or right knee jerk is this compared to the left. Right angle jerk is this, left angle jerk is absent. On disc well sit, plantar flexor. No, sensory is normal. So what will you do now in this patient? Walking difficulty despite shunt functioning normal.
Any bladder disturbances, sir?
In fact, she was not complaining much of a bladder problem.
Memory impairment.
No memory impairment. Very perfectly no memory.
The CVJ and code has to be looked for.
CBJ
and code. Intermittent, because the intermittent nature.
And I didn't get you, Monsa, right?
Craniovertebral junction and the spine.
Well, that is normal. That's all normal. They looked at very well. I showed only that 11 film. CBJ was many times MRI was done. That's all.
May not be pure NPS, sir. Maybe vascular component and lower body Parkinson's.
No, I didn't. May not be NPA, supra Parkinson disease. But she
vascular Parkinsonism, because the MRI changes showing peregrine white matter changes.
But every time we did the shunt or this thing, the patient improves very well. So all these videos were shown after the treatment was given.
CSF.
CSF type. I didn't get
the flow study may help to differentiate.
Studies, I don't know. It was not. I don't know whether it was done or not.
CSF is normal, sir, on testing.
That I'll show you the later on. The one on CSF I'll show you. So what do you do now?
Yes, if the protein is not normal, so there is a tendency for that to again getting blocked.
You mean to say, in NPs we don't get elevated CSF protein. No, this has been there for many years. You remember that patient? The patient has been having this problem for many years.
The tap may not be functioning now, sir, because she improved after the CSF was removed.
Yeah,
if the tap was functioning, she should not improve.
Right, but that's improvement is only improved, but transient improvement.
If the tap was functioning, she should not improve. No, sir.
Yeah, if it's still that, but that is a logic you thought. I also had the same logic. That is, in fact, I only advised CSF type when the shunt was functioning. But to find out whether but the improved, but we were happy, but again she was sick.
But at that time, ventricle size was very much normal, sir.
It has become reduced compared to the previous one. You're perfectly right. So
Did any of the MRIs show the CSF flow void in the aqueduct?
That I don't have the MRI with this, only MRI which is available sent by the patient. The one thing is certain, she has NPH because otherwise she wouldn't have improved that much. But the walking difficulty is still persisting. What is that the problem? Okay, so what will you do now?
Repeat MRI.
Now let us look at the gait once again. It is the gait which may think other some other problem. Any thoughts? I'll show another bit of video of the same patient.
Some amount of heel dragging is
Some dragging is there on the left side, no? Don't you think so?
Yes, sir. Yes, sir. Left
Yes,
dragging.
yes. So that's the thing I had also thought. And the gait was not like an NPH gait. It's not like a frontal gait. I'll do the videos. Now I'll show two classical frontal gait disorder. This is not. It is armsing and short steps. And they got normal tapping movement. But this is from the Continuum Journal, the one case showing by the NPH frontal disorder gait. So our patients are still different. Now let us see the next video of the patient. What did I do in this patient?
But walk like that.
She had weakness of the left foot is coming down. Did you see that? Right is still down. And she cannot walk on. She cannot walk on heel. Both were. Bilaterally coming down more on the left side. She has got pivotal turning. That part is there. Which is there. But the walking difficulty is not due to that thing, but due to reverse suppression and reflection. And she walks in the bend. So it is a gait abnormality which should make you suspect something else is operating. Now go back to the findings. Her left knee jerk is decreased, left ankle jerk is absent. I'll show that finding once again.
Okay. Okay, buddy, okay. This book, beto. This body worry, buddy, come on. Beto. This picture. Beto. And picture that the neck, you take a summing kill it. The book, picture. Put it. So, you to matter.
The left knee jerk is right is brisk, left is decreased. Right knee jerk is well suitable. Left is absent. And she is dragging on the left side. Whatever dragging observed was the left side. If it is not a pyramidal lesion, it's a pyramidal lesion on the right side, right lower limb should have dragged. Since the left lower limb is dragging, that means you should have a plantar flexor weakness. You know, weakness can have dragging. That is why it looks for the ask the patient. So always ask the patient stand on heel and toes to detect mild weakness. And one more point is the history is that she was complaining that both the feet were feeling wet. That means she has some sensory symptom on the sole. So what do you want now?
No conduction.
Conduction.
That's fine.
Before
MRI,
that,
that's fine.
MRI or the LS spine to find out radiculopathy. Okay. So this is a sagittal T2. There's some mild disc protrusion, but no root cause. The sagittal T1. The nerve roots are all very well seen without any compression. This is an axial T2. Again, this MRI sagittal space sequence showing the root very well seen without any compression. This is there, but it's not compromising the nerve roots. The root rod can be seen very well. They are very well seen. So what else you need? NCA study, no? To find out if the problem is peripheral or not. So NCS was done. Normal CMAP amplitude in the conperoneal. Superficial also sensory is let us see the amplitude 8.2. Okay. And superficial normal. Sensory normal. HFA plus normal. So what will you do now?
EMG, sir.
Okay, EMG can be done. Before that,
Spine memory.
he has got definite findings, no? He has got absent reflex on that side. He's got weakness bilaterally more on the left side. The side with plantar flexor weakness has got a absent jet. Those flesh is weak bilateral.
H reflex can be done, sir.
Correct, very good. H reflex. H reflex was absent bilateral. So it shows that patients got a radicular involvement. Okay, that is why NCS is normal. Sensory potential is well preserved. So H reflex is out, radiculopathy is there. But radiculopathy with the normal MR. So what do you like to do now?
Study for diabetic.
So I checked, I wanted to verify myself. So when the H reflex may presence, that was there, it is absent. It was not there on both sides. No achievement you've seen. This is on the other side again, so that forward. There is no HC seen. It's a minimal potential seen, but it's not true H reflex. H reflex with by the end it should come down. There's no H reflex on the other side also. So what else you need now? Yes, got the radical. Pardon?
CSF, sir.
Very good. CSF. In fact, I did not do the CSF. In fact, CSF was already done earlier because of the CSF tab. So I digged up the old report, and this is the old report. CSF protein is 130. So what is the diagnosis now?
CISP, sir.
Demyelination.
Pardon?
Demyelinating.
No,
CISP, sir.
most likely can submit a aspirin. Demyelinating, the nerve conduction is normal. Sensory peripheral conduction is normal.
CISP, sir.
Only confined to those two nerves only, very unnecessary. Most likely she's having some arachnoiditis secondary. Patient undergone repeated CSF tab now. In fact, only Malaysian suggested this possibility. I thought that's a very good likely possibility here. That is, repeated tab can someday lead on to arachnoiditis.
But MRI contrast is normal, sir.
Well, in MRI contrast, in fact, contrast was not done. In fact, if I asked for a contrast study to be
Then
done.
Then we need to do the
Yeah,
contrast.
because because I look for a disc prolapse. That's what we need to diagnose suspected radiculopathy. So I thought I'll do an MRI first to find out what disc prolapse. That is not there. Then they did a conduction to find out it's a peripheral problem. That is normal. Then they actually then again, by the time already MRI was already done. Then I have to go by the time then I want to look for the CSF. Then the patients could do another MRI with contrast. So it's in fact I sent back the patient to Kimberly to do the CSF contrast and repeat CSF and CSF contrast. The MRI contrast. Okay.
But this is one doubt, sir. So, but this is acute. This is recently only. So, what was the cause for her?
No. I'll tell you. What was the cause? This is acute or chronic? We do not know. Because every time patient is improving, but this walking difficulty is persisting little bit all the time. So when the NPH worsens, the walking difficulty worsens. That worsening improves every time with CSF tap or surgery, whatever it is. But underneath this weakness was persistent. Initially, it was total improvement. And subsequently, over a year, this is dating back to 2018, 17 or so. That means about 6 years duration. So this weakness must have been there earlier. Because we are only concentrating on the person's gait. Okay, and walking difficulty. And every time improving thing, naturally, NPH only we think. So sometimes two diseases can.
But if it was for quite so long, then it should have been significant wasting on the left side.
Correct. It all depends upon how severe it was affected. Their weakness is not very severe. See on examination at the bedside, the power appeared normal. You see me examining, appeared normal. The only thing is when she cannot walk on heel and toes. That is only mild weakness. Mild wasting and all you can't pick out that easily in a deep-seated muscle.
Sir, how we are trying to
Pardon? Yes. Rose?
Sir, how we are trying to manage this arachnitis, sir, in this patient?
No, it's a good question. So this person's disability, you are make them convinced it's only mild walking difficulty. You get along with them, don't do anything. See, whenever you opt for it, this has been there for some time, long time. She's still able to walk over. See, the last video the patient has sent, taking that flower pot and all. Okay, relatively okay, except that she cannot walk very fast. So in the treating arachnoiditis is not that simple as treating a disc prolapse. With the disc prolapse, we can take it out, the disc can be improved. Arachnoiditis, the treatment, the benefit of surgery is dubious. Moreover, if you tackle with that arachnoid membrane, then further damage can occur in the nerve roots. So unless it is significantly progressing, don't do anything. Wait and watch.
Okay, sir. Thank you, sir.
Sir, when is the arachnoiditis, sir? When the patient might have developed?
Look, arachnoiditis only one of the postulate which Dr. Murali was considering, which I think is correct. I also the same line of thinking.
But the duration of arachnoiditis, when she might be having, when she would
Because
have gone
she has been undergoing repeated CSF tap many times. Okay, for the over the 7 years, many times she's undergone.
But she had once a shunt infection, so that can cause rice proteins. That may persist, no, sir.
No, actually, I didn't hear you. Can you repeat once again?
She had once a shunt infection, so that can cause the rice proteins in the CSF for a very long time.
Yeah, that's exactly what he said is perfectly right. She had a shunt infection that would have caused the problem also. Very good. Even
Sir, but the gate was there in the first video also, no? So the gate left. Can you show the first video, sir? The gate was there.
Exactly. The first video is also it is there. You are right. In the first video also some weakness wasting was there. Not in the first one. First one we don't have it as. The patient improved totally well. Nobody took the video. Subsequently, only after the other videos or subsequent videos.
So cells in CSF.
Cells in a, there's no in a cell count. I'll show you whether it was there or not. No, this is the report which digged out from the old record. The cells was not mentioned at that time. This is not the CSF done now. It was done on when the CSF tap was done. No, at that time it was whether CSF was looked for or not, because nobody was suspecting an arthritis at that time. We did it. It's only routine tap to relieve the NPH.
Did she complain of back pain?
No back pain. But not retrospectively asking, after seeing that finding, that I asked if she got any problem in the lower limb while walking. She was feeling aching pain in the lower limb while walking and walking. It was there. But that's only on reading question after finding out the weakness.
Yes.
Okay.
She definitely has NPH now, sir. No.
She does just have it. She has NPH, no doubt about it. And over and above the NPH, she has got this problem.
Diabetic or no, sir? You say diabetic.
Yeah. This diabetic was detected later, came up later, not was present earlier.
Any chance for mononeuritis multiplex?
Very unlikely because the nerve conduction, peripheral conduction is normal. And H reflex is absent, pointing to the lesion in the root.
Sir, what is your opinion about the possibility of considering endoscopic third ventriculostomy after the patient had a shunt infection? Repeat surgery for NPH?
No, which I don't know. I cannot. I think I have to ask the neurosurgeon regarding that thing. Because I have not done for that thing for my patients. Because most of the time they improve with CSF tap alone. And they, even after one tap, one tap means 3 times to do the tap, and patient may remain asymptomatic for months and years for reasons unknown. Just one tap and one tap in the sense that one admission may remain long, perfectly for many years. Some other people after 3 months come back with worsening. And that patient may invariably land up in doing shunt surgery.
Yeah, shunt surgery is obviously the definitive treatment of choice if they need a surgery. But if they have a shunt infection, then some reports suggest that third ventriculostomy may also work.
Yeah, correct. You are perfectly right. Because this is the first instance, time I come with a shunt infection. That's very common.
So the left foot weakness can be due to cortical, so if you exclude the H reflex one.
Left foot weakness?
Weakness can be due to cortical cause, no sir? She has white matter lesions in the brain. The left foot
No,
dragging and all.
No, it's not a cortical because he has got a plantar flexor weakness is there. That is where in pyramidal lesion you can dorsiflexion more than the plantar flexor. More angle jack is absent. And
Ankle can be due to mild radiculopathy, no sir? Disc or due to diabetic.
He has got a weakness of the left foot and that reflex is absent. H reflex mean you would think of a lower motor neuron lesion. Nothing to suspect human lesion. There is no spasticity in the left lobe. The dragging is because of the plantar flexor weakness. Plantar flexor weakness, when plantar is also downgoing, flexor. Nothing to suspect a pyramidal lesion. Okay, shall we stop for one more case?
One more.
Okay, so that's a interesting case. Now this one, the point I want to mention is that initially also when I started examining, I did not suspecting. Seeing the gait only, I had a suspicion of that dealing with something else. So always when you get doubt, always make the patient stand on heel and toes. That's a lesson I have to tell you. Because I have gone wrong many times previously. I was not doing this kind of a testing in the bedside. But now I started doing this for every patient, suspecting walking difficulty. As the patient stand on heel, I walk on heel and walk on toes. Okay, so that's it. Now I go to this is a story of a 14-year-old boy. History difficulty in writing, abnormal posturing and tremulousness of the right hand for the last 4 years, which has increased for the last 2 months. No other complaint. No positive family history. These are 2-3 short cases. Speech is normal.
ഞാൻ ഇപ്പോൾ തിരുവനന്തപുരത്താണ് താമസിക്കുന്നത് എന്ന് പറഞ്ഞോളൂ. കൈ ഇങ്ങനെ നീട്ടി പിടിച്ചോ. നേരത്തെ പിടിച്ചോ, ശരിക്കും പിടിച്ചോ, ഇങ്ങനെ പിടിച്ചോ, ഇങ്ങനെ പിടിക്കും.
This is also Roy's case. It's got tremulousness to the right hand. The myoclonic jerking. An abnormal posturing. Jerking. And if the abnormal posturing of the right shoulder goes up.
മൂക്കിത്തൊട്ടെ, മറ്റേ മൂക്കിത്തൊട്ടെ, ഈ വെള്ളിത്തൊട്ടെ. ഇത് തൊട്ടുകൊണ്ടിരിക്കേ. ഇനി കൈ കൊണ്ട് ചെയ്ത് മൂക്കിത്തൊട്ടെ, വെള്ളിത്തൊട്ടെ.
Left side is not there, mainly the right side.
കൈ നൂർത്തെ, കൈ മടക്കിക്കേ, അത് വിട്ടോ, മുറുക്കി പിടിച്ചേ, മുറുക്കി പിടി, പൊക്ക.
Only power extended reflexes sprawl normal. There is no abnormal posturing of the lower. Yes, next part of the video. Dystonia with myoclonus. See the myoclonus. Now ask him to right, the dystonia becomes big. Dystonia of the fingers as well as the shoulder. Severity of rightness. So dystonic posture of the right hand associated with myoclonus, irregular tremor of the right upper limb, especially while keeping this hand outstretched, more so while writing. I can occasionally, let's just say this. So MRI normal, serum ceruloplasmin normal, no care. So what is the likely diagnosis you want to keep here?
Dystonic myoclonus, sir.
So myoclonic dystonia is
Dystonia.
okay, right. Okay, let's see. So it's 2-3 similar cases also. Let us keep this patient's picture in mind. Now another patient, this patient has shown something back. The story of a 20-year-old woman, history of tremor of the right head associated with jerky movements of the right hand for 3 years, occasional dropping of objects from the hand, episodic forward movement of the trunk and neck for the 1 year. She has got jerky movements of the tremor and this is the myoclonic movements. See the jerk. This is the jerk. Sudden jerk. Again, sudden jerk with the neck and hold trunk. See that? With the head, see the head. Okay. She's asked to write. So not much of a dystonia, but jerky movement become very prominent. It's also good dystonia. So this is another second case. A third case, a similar one. Just could severe dystonia in the hand. Look at the hand writing. The way he holds it. She has also got jerky movement in the head and the hand. And look at the gait when they stand, it's jerky movement. See the jerky, lightning jerky. Okay, so I showed 3 cases in similar phenomenology. One boy with right upper limb dystonia with jerky movement in the hand. These 2 girls again with prominent right chest cramp. The third one, prominent right chest cramp, jerky movement in the head. Second one, not much of a dystonia, but again mild dystonia with prominent jerky movement. So what do you think the diagnosis in each case?
DYT 11. DYT 11.
All are macular dystonia.
All are macular dystonia. So the second and third case, I had no doubt it was some typical macular dystonia because they were the so-called lightning jerk. That is the classical description of a macular dystonia. See the lightning jerk, I can show the lightning jerk. See the patient, see that jerk. The second patient also had that lightning jerk. The first patient, frankly speaking, I thought myoclonic dystonia, but let us see what happened to the second and third case. This diagnosis is correct. It's a myoclonic dystonia, that is sarcoglycan gene mutation. This is the second case. This is the third case, again myoclonic dystonia, same mutation. When the other thing was different, amino acid, this was different, but same protein was affected. Now, regarding the first case, this which I don't shown earlier, with prominent dystonia with lesser myoclonus. In myoclonus is there. He had DICT1 dystonia, Rosin1 dystonia. Now, previously we have been taught that classical dystonia muscular deformity starts in the foot, gradually progresses along the upper limb, but need not necessarily be. It can start in the upper limb once more, upper limb alone. And recently, apart from this classical presentation, the one with predominant right chest cramp alone can be the manifestation of a DICT1 gene. So that variants have been described. So this I also in the first case actually a torsional dystonia. It is called dystonia muscular deformity rather than myoclonic dystonia. The myoclonic dystonia, they respond very well to treatment. Now, all the patients have responded to clonazepam high dose, some of them with sonizumab. But if it is torsion dystonia, the patient has to go DBS is the treatment of choice. So torsion A mutation. So this is again from the literature. This presentation can be queried but varied. One likely pathogenic TOR-A mutation for treated cervical dystonia patient. The genotype phenotype correlate can vary, indicates that clinical spectrum of this type of dystonia may be broader than previous classical descriptions. This is another patient which I had earlier. This case I have seen much before the genetic tests were available. But I confirm the diagnosis one method. Can you tell me what method? I'll show you. This is the patient. Severe dystonia and myoclonic.
എന്ത് പറഞ്ഞു മറ്റേ ഇപ്പം മറ്റേ കണ്ടിപ്പം ഏത് വിളിക്കാൻ ഞെട്ടില്ലായിരുന്നു കൈക്ക്, അല്ലെങ്കിൽ തെറിച്ചു പോയി. എങ്ങനെ ഞാൻ കാണിച്ച്
What is the method which I used? Can anyone tell?
Sensory tricks, sir?
No, he improved remarkably with one treatment, one test, in fact.
Clonazepam.
No, he'll tell the next video.
Just a antagonistic. Just a antagonistic.
ആൽക്കഹോൾ വ്യത്യാസം വന്നില്ല. അവർക്കൊന്നും ആൽപ്പം ഓർക്കുന്നുണ്ടോ?
Probably Umba may be remembering this boy. I brought brandy and brought the patient to my room and gave him. Do you remember?
Yes, sir. Yes, sir. I remember.
And he's telling that thing, sir. I forgot. I totally forgot about this thing. Sir, I remember.
ആദ്യം നോക്കിയത് അതിന് അത് കഴിച്ചിട്ട് വ്യത്യാസം വന്നില്ല. ഓർക്കുന്നുണ്ടോ? ആൽപ്പം ഓർക്കുന്നുണ്ട്. അത് കഴിച്ച വ്യത്യാസം വന്നിരുന്നോ? മദ്യം കഴിച്ചപ്പോൾ പൂർണ്ണമായിട്ട് കുറഞ്ഞായിരുന്നു.
He's telling that with alcohol it's almost totally disappeared. That's the technique by which used to diagnose myoclonic dystonia at that time. Because myoclonic dystonia is one condition which is alcohol sensitive, just like benign essential tremor. So this is only to show that the DICT1 gene can have varied presentation. Some can present with the writer's cramp. And this is the one. Dystonia can present with writer's cramp or upper body segmental dystonia, mild severity. This is another mutation. I think I'll skip all these things. Dystonia. Okay. Any questions? We can wind up.
Last case was a DIT1 or DIT11, sir?
Which one? You mean the third one?
No, the last one who took the alcohol to.
No, that genetic test was not done. That's a myoclonic dystonia. In its dystonia, some myoclonic dystonia, in dystonia may be very prominent, confusing with this thing. But all of them have got the classical lightning jerk. This boy also got myoclonic, just jerky movements was there. But why I thought it is myoclonic dystonia? Because only responded to alcohol very well. In DICT1 dystonia, you wouldn't have responded to alcohol. He himself is telling now that I totally became mental.
But its dystonia is very prominent. It's like a torsion takes.
Exactly. That's so the myoclonic dystonia can be variants. One more type. I forgot that type. Where the this one, I think it may wait and see. Where the myoclonic dystonia might see here, see this one type of myoclonic dystonia, the one with DICT26, the KCTD mutation. Here the dystonia dominates the clinical picture. So some of the myoclonic dystonia, the dystonia may be prominent, myoclonics may be less prominent. So that's why it causes confusion with myoclonic dystonia. Sorry, with DICT1.
Myoclonic dystonia is DIT11 and DIT26 or any other DIT?
This is another one. This is the myoclonic dystonia due to KCTD mutation. Other two is sarcoglycan protein. This is another protein. I do not know what protein. This is a DIT11. Okay. Shall we stop? Any questions?
No, sir. Thank you.
Thank you, sir. Good night, sir.
Thank you, sir.
Thank you, sir. Good night, sir.
Good night, sir. Thank you, sir.
Good night.